So welcome to this video where we're going to discuss the prescription correction range with Nocturnal. I'm Scott Brown, optometrist at Scotlens. So looking at the range that we see, so we've got this optimum range of patients that we want to fit, and these are generally the spherical equivalent minus 550 patients. These patients are going to expect a good outcome where they're not really going to have any need for part-time glasses over the top to enhance their vision. Now there's also published figures that we see, and that tends to be sort of up to -6, minus 150 still. And these are patients that can be successful. It does rely on a few things from the point of view of the lenses, the treatment zone being very centered, the patient probably being a bit tolerant to lower quality of vision, or that they may need to top up their vision with part-time glasses, perhaps for night driving or for detailed close work. And from a manufacturing point of view, we can effectively make a lens that's going to fit and theoretically correct any prescription. But again, this would rely on a very good patient and high tolerance, or the fact that they're prepared to accept glasses on a fuller part-time. So working out, understanding why this works, lets us understand these limits. So we can see we've got a lens on the eye here, and what happens when the lens gets worn is the epithelial cells thicken in the mid-periphery. So when the lens removed, we've got this treatment zone created of the minus prescription that we need. And it's this epithelial cell thickness change that limits the corrections that we can get. And we're limited to about making a 20 micron thick change to the corneal epithelium. This, of course, is temporary and it wears off. If you stop wearing the lenses, your epithelial cells just shed and they go back to normal. You can see the thickness difference here from the histological slide. So this 20 microns is linked to the prescription that we're correcting. So if we correct a -3 prescription, we can create that 20 micron thickness change over a larger area. The higher the prescription goes, if we've got a -6, you can see that the treatment zone size is limited because of the prescription. So the higher the prescription, the smaller the treatment zone is going to be, and you can see it quite clearly here in the topography. So higher prescriptions means possibly more glare, or if there's any lens decentration, it's going to cause emphasize the effect of that high prescription. When we think about astigmatism, you can see here we've got a toric cornea, and we would fit a toric contact lens to fit that eye. Now, if we then consider the base curve of the lens, now the base curve of the lens, which is designed in the flat meridian, is going to be naturally steep meridian. The base curve is going to give us more of a minus tier lens thickness. So we should, in theory here, say correct 3 diopters in the flat and 5 diopters in the steep. But that's not actually what happens. What tends to happen is you get this 20 micron thickness change all around the cornea. So we're going to correct -3 in both meridians. So if you've got corneal toricity, you're probably going to end up with a residual sill in the steep axis. And you can see the topography. We tend to get an oval treatment zone with a toric lens. So this is where it's a good assumption to make that we're going to get a spherical equivalent correction up to that limit of a -550 best vision sphere. Or another good way of testing it is to fit the patient with soft spherical contact lenses. And that will suggest the outcome that they're going to get. So optimum prescriptions up to -50 spherical equivalent, and then higher prescriptions, yep, they can be done. Theoretically, they should work. We're going to discuss a bit further on in topography about what might work better than others, but effectively, you're going to anticipate that there's going to be a residual prescription left over. The other factor that we need to take into account is how long do the corneal changes take to stabilize. So it's going to take about 2 weeks for the corneal epithelium to stabilize, so the patient's got stable vision from when they wake to when they sleep. The bulk of that happens in the first 3 or 4 days. But if we're going to make any lens changes, we want to wait for the patient to have worn that lens for 2 weeks so we know the extent of the changes. We look at 2 successful cases. Patient on the left is a fairly clear-cut, successful patient, -3 prescription, low astigmatism. Motivation is because they hate specs and they're very sporty with a contact sport. And the outcome from them that was expected was the best vision sphere was going to be successful, and this patient doesn't need to wear glasses over the top at all. So they get 100% correction with the Nocturnals. The patient example on the right, different candidate, high astigmatism. His motivation was not for daytime vision. He works in finance, has a very demanding, detailed vision job. But his motivation was that on the weekends he could see without any contact lenses in, which he was risking, or which he was losing with his daily disposables. And he had a vision that was going to be appropriate for him competing in Ironman and practicing for Ironman competitions. So his vision is adequate. His myopia is gone, but the residual still is there. And he then wears glasses on pretty much a full-time basis at work so that he can see. So he's wearing the nocturnal lenses for the lifestyle benefits at the weekends and for his hobbies. If you'd like to keep watching some more videos in the series, if you need any more information, email lab@scotlens.com, and thanks for watching.